Thanks, Lee. I must be, I'm glad to see that poster has changed today, so thanks very much for that. Look, when I got given this title, I thought, how do I sell Standard 7? What topic have you given me, Lee? Blood and blood products, why for Standard 7? So I thought about this quite a while, and what I really think I'm going to do with this topic is to try and think about what we're currently doing in the hospital, what my current role in the hospital is, what gaps might have been there before we knew anything about Standard 7, and going to our hospital, what has changed after we've tried to implement Standard 7. This is a picture of, I just been recently in Dubai, so that's a shot from Mission Impossible with Tom Cruise going down the Burj Khalifa. Amazing photo, amazing place to go, an amazing place for a holiday. So I thought it was a bit like Mission Impossible, but I think I managed to put a talk together. So let's see where we go. In terms of my role, I think that's where I look at what I do. What is my role? What am I trying to achieve? I'm obviously a clinical haematologist. My focus there is patients. So what do I want out of a system? I certainly want safe blood products. I want guidelines on when I should transfuse blood products. And obviously the theme going through is I want to minimise harm and maximise benefit. So one of the things we're developing today is a real patient focus. So coming to this clinical haematologist role I think is extremely important. I'm a supervising pathologist. I supervise the laboratories at Gosford and Wyong hospitals. So what I want there is my procedures to match national standards. I certainly want safe transfusion practices. From a laboratory point of view, that's the worst thing that I could happen in my laboratory, that things we do are not safe, do not meet national guidelines. I want to obviously reduce risks of error in the transfusions, but I also have a responsibility to minimise wastage of products. I also have a governance role, which I thoroughly enjoy. I chair the local transfusion committee. I chair a few other committees, and I have in the past as well. At a hospital level, what I really want to do is get engagement from the local hospital in my committee. We've been extremely lucky at Gosford Hospital that we've had great commitment from the hospital. We've had a great governance and a great working relationship. I want to implement the right policies, and through the transfusion committee, I want to see what we're doing is being monitored and we're auditing, so we're confident that we're implementing the right things and we might be changing practice. So I guess I thought, Standard 7, where do I go with this? One approach might be to say, all right, I've heard about this Standard 7, I've got a transfusion committee, I've got policies, I've even got haematologists. So maybe I'm already doing a lot of it. So the question quite appropriately comes, why do I need to look at Standard 7? Where am I going with this? Because out of all those standards in the new guidelines, probably transfusion's been doing this maybe the best for a long period of time. We have been measuring things. So what is going to change now that I get given Standard 7? So I work at Gosford and Wyong hospitals. This is a total of 870 beds. As I said, I've got no one from governance here, so I'm not trying to sell myself or sell the hospital, but I do think it makes a big difference. We've had a commitment to a full-time transfusion CNC now for 7 years. And so some of the situation that we're in and where I look at Standard 7 going has been very prejudiced by how lucky we are with having such resources. We've also had a functioning transfusion committee for 7 years. We meet every month, and our attendance is probably 80–90% on each of those meetings. So we're in quite a privileged position. So I'd have to say we have an excellent working relationship, so we can introduce things very well. Our blood management committee, as I said, it meets monthly. We set this up mainly as a governance structure 7 years ago when I was asked to chair this committee, because I thought to change things, I've got to get governance on track. Whilst we have a smattering of representations from divisions, anaesthetics, trauma, cancer services, maternity, laboratory, transfusion, CNC, it's a very heavy governance role. So we have the medical super, we have links to the directors of nursing, we cover both of our hospitals. And what's interesting over time is I'm now getting more regular representation from the divisions. Anaesthetics who usually would say, I'm a bit too busy to turn up, nothing interests me, they've been regularly turning up. We've got a trauma C&C at Gosford Hospital. They've been regularly turning up. So our transfusion committee structure, we've been very lucky that we've had good representation and it's a regular meeting. We have been measuring for quite a few years our KPIs. I guess from my previous history of the Red Cross, of chairing a lot of committees there and how people corrupted my doctoring into trying to do some managing styles, I always look at trying to get a KPI for a meeting. So for a long time, we've been measuring our fresh product wastage. We've been doing audits, and those audits have predominantly been on wastage and also appropriateness guidelines. We've looked at adverse events. We've always reviewed the IMS in the hospital to see if there's any messages there. More recently, we've been looking at financial reports, risk management, quality improvement. We have a direct link with the New South Wales Blood Transfusion Committee, looking at education and policies and procedures. So once again, before Standard 7 came into play, or even we heard about it, we're already doing quite a few of these issues. Standard 7, I think one of the main messages from that cover sheet is implement systems to ensure safe, appropriate, efficient, effective use of blood and blood products. We'll hear today just different categorisations of that, but that's what we're on about. We're looking after our patients. We're also respecting our blood donors. What I'd like to do now is just sort of go on to some of the things that I thought we were already doing reasonably well in our environment, and obviously that environment would not apply for everyone who's here, so I'm lucky that I've got a great transfusion C&C to help me out. If we think about some of the specific requirements on Standard 7, 7.7, have systems to receive, store, transport and monitor wastage of blood. We've been doing that for quite a while. Minimising unnecessary wastage of blood and blood products. Again, looking at that for a while, and I would imagine a lot of transfusion committees at times have been looking at that, or there's obviously an increased focus on it. And the emphasis here is ensuring donor blood is used efficiently. So if I was to give us a report card and sort of say, well, what do I have to change with Standard 7? I could say from a strictly laboratory-based point of view, I'm probably doing quite a bit of it okay. I'm essentially documenting a lot of those measures. I'm reviewing those measures, I'm benchmarking them. One of the good things now coming out is there is more benchmarks being produced, as opposed to before you might have thought, oh yeah, I think I'm doing all right. Now we're seeing from New South Wales Health and the Ministry, oh, here's some guidelines where you should be going at. And maybe with Standard 7, I need to tidy up a bit, but some of the strictly based laboratory things, I mightn't have to do too much. Maybe this is why my Director of Governance said, I'm not worried about Standard 7 for transfusion, we're going to do great with that. I'm a little bit nervous being in charge of it, but maybe for some of these things that we've been doing for a while, hospital administrators and governance think this is one of the easiest ones to get through. Another example, policies and procedures, 7.1.1. Policies and procedures are consistent with national evidence-based guidelines for pre-transfusion practices, prescribing and clinical use. The use of policies, procedures and/or protocols is regularly reviewed. Look, this was something that I keep in a lot of my slides, and it's sort of, when I came back from being at the Red Cross for 8 years back into clinical practice, this was actually an article that appeared when I was on call as the director for the Red Cross for the weekend edition of the Sydney Morning Herald. This came about the time we did our initial guidelines, where I was involved in that in 2001. Doctors continued giving blood transfusions to patients after being told they did not need the treatment and then it could kill them. Now that was a good headline. I was a bit like Deborah defending quite a few people at the time, but it does underlie the message, and I think we've improved that message over time. So at Gosford Hospital, we certainly did spend a lot of time implementing the previous guidelines, the appropriate use of products. Blood, interesting how things have changed. We titled this back in 2001, Blood Components, a Guide for Patients, where really what have we done, sorry, just, wait a minute, I think I've, okay, it's, all right, we'll just go on. It's doing things with my slides. I'm really want to, That's all right. We talked about, at the time, appropriateness. That concept was introduced in the early 2000s. The decisions regarding blood, aware of the risks of blood transfusions, aware of the benefits of transfusions, and it was meant to be a balanced decision. I think it was a good message that we continue to talk about. The difficulty that we had with this was really finding evidence on the benefits of transfusion. And I think as much as people say, oh, well, yeah, I understand the risk thing, tell me what are the benefits of transfusions? And certainly on sharing the medical module, one of the real troubles there in putting out a lot of clear recommendations is there's not a lot of evidence on the benefits of transfusion. So we certainly talked about that message for many years at Gosford Hospital. We certainly, however, were product-based. And I think we'll all say about the conclusions back in 2001 when we first started doing this, we were very product-based recommendations. Pleasingly, with the new guidelines, we've shifted that. We've shifted from product to patient-based guidelines. And at Gosford Hospital, we're now certainly, when the module came out, developing our patient blood management policy to replace the component-driven now towards a patient-driven, and we're certainly improving our cares for patients. So where do I see that summary going? I see that going that, did we have policies and procedures in place prior to Standard 7? Yes, we did. At the same time as Standard 7's coming out, I'm sure it's the logic between people writing those standards, we had shifted from product-based to patient-based. So I think this drive here is complementary with Standard 7 coming out, that we're changing the direction of our policies. Now, I think one of the problems with all these policies is when I first entered transfusion quite a few years ago, the only one putting out guidelines was the then ASBT, obviously now it's ANZ SBT. So there was just one place you went to. You went to the ANZ SBT guidelines, said, here's the guidelines. They were, however, essentially only laboratory-based. But what's happened over time? Everyone's sort of having now a bit of putting their guidelines out. So you've got some NATA guidelines, you might have some NPAC guidelines, you've got some excellent NBA guidelines, quality guidelines, the ministry might be putting guidelines out. And then you go to your hospital level and they say, now let's put out SOPs for these things. So we have a safe blood collection SOP, we might have a massive transfusion SOP, we might have a patient blood management pre-transfusion, blah, blah, blah. And I think if we're not careful, what we're doing is a very disjointed approach to implementing guidelines at a hospital level. Who's pulling all these things together? And the Transfusion Committee, yeah, it can do that, but there's a lot of work. The other point that I'll keep on coming back to is one of the downfalls of perhaps a transfusion committee, especially if it's run by a lot of governance people, is the hospital might see the ownership of transfusion issues by the committee. Oh, they're doing that stuff up there. The CNC is doing the audits. They're running that for us, and it can almost be pushing it back up. So the problem we had is, yes, we're implementing all these policies. We know what we've got to do. We can reference all our procedures back to national guidelines. Bit disjointed, a lot of them going on, and it could well be owned by the Transfusion Committee as opposed to maybe the nurse on the ward. So we established a National Standard 7 Working Party Committee. It's chaired by the Transfusion CNC. It has good representation. It has governance, haematology, medicine, maternity, paediatric, aged care, RMO, ICU. Look, the aim was pretty simple. This was established to prepare for accreditation. That's what it was done for. I'll go on the next slide. But it was patient-focused. And as I'll come to and develop this thought, it had a different agenda to a transfusion committee. And it was really enthusiastic. The people that came to this committee were fantastic. They were really keen, as if you're giving them ownership of something new. The agenda items, Standard 7 gap analysis. So what we're basically doing is preparing spreadsheets, looking at all the issues, looking at places, saying, where is there gaps? So that's where it started off. We want to pass accreditation. I want to make sure we pass accreditation from the hat that I'm wearing, but that's what the agenda was. But what other things do we look at? Ensuring the audit program meets the standard. Consumer engagement. We're still working on that one. Area-wide approach to implementing blood safe e-learning. What I'd like to do now is from where I thought, yeah, we had everything in control, just to show the changes that have happened since implementing Standard 7. So one of the things from my transfusion committee that I thought we had controlled was informed consent. We do audits every month or two, present those to the transfusion committee. Yeah, they're not necessarily 100%, but they may be close to 100%. I felt reasonably confident in that. So we've audited, I thought it was acceptable level. We had introduced a cultural change across our hospitals that if there was no consent, there was no transfusion. RMOs get really upset, but it really has been enforced at the ward level. If they can't find a consent, there's going to be no transfusion. We looked at guidelines for how long that consent should be valid for and regularly transfuse patients, and I thought we had that in control. So when people wanted to raise this at the Standard 7 meeting, I thought, oh, we don't have to worry about that. But this is what they found. They found the New South Wales health form, and I'd been looking down here to see if it was signed, and one of the nurses at that meeting said, and also our transfusion CNC, hey, there's a little clause hidden here. I do not consent to blood transfusion. And we went back, and this wasn't being completed. So for some of the transfusion, there mightn't have been a cross or anything through it. So we looked at that saying, if we're going to document things in sort of a quality improvement process, well, one, we might go back to health and say, hey, can we do something about this little cross-out thing because we're missing that. But this, not making any of this up, this came up through this committee. And as I'll lead to, this issue here has now gone to one of the things that we've pushed down to the ward levels on a monthly basis. For the NUMs are going to do this across 10 patients on their ward. Check, not only have that's been signed, has that been signed? Small thing, but it was an improvement that we totally missed, and I thought we had this in control with a different group of eyes at a transfusion committee. So the summary was we found many people didn't have this completed correctly. We're moving it now down to a ward level. So this is not going to be the responsibility of, whilst with the transfusion CNC will do it, we're pushing it down to the ward level to get the NUMs and all that to do these on a regular basis, and we're going to measure it at a ward level. Another example, undertake quality improvements to improve, 7.4, to improve the safe management of blood and blood products. 7.5, as part of the patient treatment plan, the clinical workforce accurately documenting relevant medical conditions and indications for transfusions. What we'd done many years ago when the previous guidelines came out was in our request form, give them something here to fill out. My logic of doing that was, one, if we kept on reminding doctors, here it is here, I want you to tick a box, at the very least it might provide an ongoing stimulus. Oh, that's right, I should know about that. The downside of that was that these forms got a little bit of scrutiny at the laboratory. They were not, however, entered in any database. That didn't go anywhere. It was looked at the most by the laboratory person, yes or no, did they complete an indication? Didn't go into a database, it went into the pathology system, it was not in the patient's notes, and more importantly, it was not available to ward staff. So whilst we thought we were doing something, we really didn't achieve it at the ward level. We kept it back up in our governance and laboratory area. So what are we doing now? Our new pathology form does not have those indications on it anymore. We're changing this to require the indications to appear in the patient's notes. It's a change in culture, but I think more importantly, the same theme I'm developing on. We're pushing this to a ward level. It's sort of saying, the nurses now, look at this in the notes. One of our other simple questions we're going to do, we're developing 4 or 5 simple questions to be done on a monthly basis, is this. Is there consent for transfusion? Is there an indication for the transfusion in the notes? So I'm thinking this Standard 7 is engaging more people, engaging nurses, engaging doctors, as opposed to someone else just owning this. This is leading to individual transfusion plans. We've talked about this again, and what we're now doing, we've ummed and ahed for ages about getting a pre-op or pre-orthopedic iron deficiency clinic going. That's now being implemented, so we're pushing it back down to the patient level. So what we're doing is we're introducing a series of simple questions. They're still being defined exactly what they will be, but it looks like it's going to be the lines, is the consent correctly completed, including the I do not, and the signatures? Is there an indication for the transfusion in the patient's notes? Were the correct OBs done? What it's doing is not saying the C&C will do this for you, the ward will do this, they'll take ownership, they'll get the message, well, it'll just get more directed to patients. So in summary, what's my sell? It's a true story. So I honestly think we were doing a lot of things very well. I thought we had a great transfusion committee. I thought we were achieving a lot at the hospital, and we clearly were. We were very lucky with our governance level in the hospital, and we were very lucky the support they gave us. We had a working transfusion committee. What does the new guidelines do? I think in a way it does summarise some of the current guidelines. I think you could look at your transfusion committee and say, is there a terms of reference for my transfusion committee that I should check across? I think it does allow that. I think it allows perhaps redefines a new committee. I think this new committee has got a much greater focus on the patient. I think it's engaging more people. I think it's prioritising transfusion governance. For those hospitals which aren't as lucky as I am with having a transfusion C&C with great governance infrastructure, I think this really sets the precedent. They've got to do it in a way if you like, but I think that's a great stick if you haven't got it. I haven't had to go there, luckily. I think it's getting more resources to transfusion. I think it's causing discussion and harmonisation of issues not traditionally covered in guidelines or in transfusion committees. And most importantly, I think it's pushing more issues toward ownership with a patient focus. It's monitoring different measures, and I think it can only benefit the patient. So where do I think we're going? I think we're leading in a new direction. So thank you.
Where can I find the pre-op iron orthopaedic iron deficiency program?
That's just something we're developing locally. So all we're doing there is really knowing that maybe 30% of people who come up to elective orthopaedic surgery are iron deficient. So basically we're just sort of taking the clause saying, look at reversible causes of iron deficiency. We're setting up a clinic. There's obviously quite a bit of work done in addressing how you should treat that patient population. We're just getting the resources and the engagement from anaesthetics to go and start setting that up. So we're going to start measuring their iron levels at their pre-admission checkup. If we find them iron deficient, we're giving ourselves enough time to give them an infusion prior to the operation. So I guess we're sort of picking up that clause saying, let's not use default transfusion, let's try and identify reversible causes, and that's a high percentage yield there. Yeah, look, I was really surprised at this Standard 7 meeting. They're so enthusiastic. There just was not an issue. Yes, we can do that. I don't know, maybe they're doing nothing. But do you know, they're not here, they're doing the work. Lee, I think what's happened is that maybe wrongly we've been holding transfusion back, and that the model of saying exactly that, champion running around, yes, got a lot of enthusiasm, but it was maybe thought, oh, that's her problem a bit. We push things up to her. Pushing it back down, maybe that's what we've done wrong. But there was zero problem. Now, is it implemented now? Yes, no. It's conceptual, but the NUMs and the nurses who are on that are really keen to run with it. They're suggesting these questions. They're suggesting the numbers. We sort of said, first of all, oh, maybe 10 per division. Oh, no, I think we can do 10 per ward. So it's not there yet, but what I'm struck with is sort of empowering them and giving it down to that level and patient focused. They're so enthusiastic just now. But you are right. I think some of our reason why we're in that position is we have had a transfusion. The hospital knows all about transfusion and that concept, so there's been already the ground set before we've moved on to this.
Any other questions? On behalf of everyone here, Mark, thank you very much. It was a great pleasure.